Dr. Soundarya, good evening.
Sir, good evening, sir.
So we are now live on YouTube, and you can start in another minute.
Okay, sir, but Dr. Anil is not joining us, sir.
I have spoken to him. I think he should join in another 2-3 minutes. So otherwise, if he joins on time, it's okay. Otherwise, we can take his inaugural address later on also, as soon as he joins. But hopefully, he will join.
Okay, sir.
Let's wait for a minute more, and then we will start.
Right, sir. No. I think sir joined.
Yes.
We'll start now, sir.
Yeah.
Yes. Yes. Let's start.
Hi, sir. Good evening, Dr. Anil. Let's start. Good evening, Anna, madam. Let's start.
How are you?
Thanks, sir. Thank you so much. Good evening, one and all. Welcome to the webinar series on Food Allergy Awareness Week from 11th to 17th. Today, we are having the grand finale and culminating with the overlooked phases, that is, the adult onset food allergy and eosinophilic esophagitis. For this, we have eminent faculty from India as well as from abroad. And without further delay, we will begin. I now request Dr. Neeraj Gupta, chairperson for today, as well as chairman of the IAP Allergy and Immunology chapter, to kindly say a few words.
Thank you, Dr. Sundarya. I think it is a very important topic, very pertinent topic in today's scenario. And as the food allergy phase is really changing in our country, we usually see pediatric age group more. But yes, definitely several adults also present to us with food allergy symptoms. So it's very important to discuss this aspect also. And we are very fortunate that for past 1 week, we have conducted so many sessions, so many webinars related to food allergy. And we are now going to cover this aspect also. So I wish all the best to all the attendees, and thank you very much to have on the stage. Thank you.
Thank you, sir. I now welcome Dr. Vedantan to the session as well. And I request Dr. Anil. Dr. Anil Arora is the chairperson of today's event. He is spearheading the Department of Gastroenterology, Hepatology, and Pancreaticobiliary Sciences at Gangaram Institute, Delhi. Over to you, sir. Kindly say a few words.
Thank you. Thank you, ma'am, for inviting me for this very important seminar. As is the course of events in adult GI practice, we are seeing a sea of patients which have problems related to the gut. And this concept of gut-brain axis is really taking a strong foothold in day-to-day practice in gastroenterology and hepatology. As long back as centuries ago, Aristotle said all diseases began in the gut. We do not know what do these 3 trillion bacteria residing in the gut are doing. Are they being useful or harmful to us? Are they our partners in health, or they are a partner in disease? We are yet to decipher. And in day-to-day gastroenterology, we are seeing a large number of the patients with inflammatory bowel disease. A large proportion of this may be related to the gut microbiome. And now we have therapeutic interventions in inflammatory bowel disease, which tend to target the replacement of the harmful microbiome in the gut with the fecal microbiome transplant. I think it is an upcoming field. To be honest, we know very little about it. And I'm, very fortunate to be amongst the top guns in the world. And I would love to learn from all of you.
Thank you, sir. Thank you so much. I now request Dr. P.K. Vedantan, our distinguished allergist, immunologist, and the initiator of pediatric allergy education in India. My teacher, sir, welcome. Please, can you say a few words, sir?
Thank you, Dr. Soundarya. Can you hear me?
Yeah, we can.
Yes, sir. We can hear, sir.
Good evening to all of you. It's good morning here. I'm in Colorado, USA. And thanks to IAP, Allergy Chapter, Dr. Neeraj Gupta and his team, and the dedicated speakers from across the globe. Today, Dr. Anna Nowak. And thank you, Dr. Arora from Gangaram for giving the introduction. I have thoroughly enjoyed your whole week of this incredible CME, which is actually at a very high level, international level. But I am also sorry to say I could not attend all of it. I had to attend only in certain pieces, but all I attended, I enjoyed it. Thank you so much. And today is a little bit of a different type of day, because when people talk about food allergy, we are always thinking about children. For the first time, you have introduced the concept of adult food allergy, which I'm very curious to listen to Dr. Anna Novak in the next few minutes. And as Dr. Anil Arora was saying, I just want to add one thing to it. All diseases depends upon what you put in the mouth, but now all diseases seems to depend upon what you touch also. So many things are going through the skin. So I just want to add that on, Dr. Arora. Thank you so much for doing all this. Appreciate. Thank you.
Thank you, sir. We will now begin with the session. I now begin with Dr. Anna Novak. She is an esteemed professor of pediatric allergy and immunology and is the director of the specialty at the Hansfeld Children's Hospital at New York. Madam has numerous research publications to her name, including clinical trials and research studies. Today, we are privileged to have you, madam, and we'd love to listen to you talk on adult onset food allergy and emerging clinical entity. Over to you, ma'am.
Thank you very much for the invitation and for the kind introduction. I'm honored to be presenting at this session. And even though you mentioned that I'm a pediatric allergist, I do actually see a lot of young adults and even older adults with a lot of the time it's, food allergy that continues since childhood, but sometimes it's also a new onset. Particularly non-IgE mediated food allergy in adults. So my objectives are to describe epidemiology of both IG and non-IG mediated food allergy in adulthood, and talk a little bit about the risk factors that are associated with breach of tolerance in adulthood. So in children, in childhood, food allergy is associated with a failure to develop oral tolerance primarily, where in adults who have history of tolerance, obviously something happens to breach that previously established tolerance. So just to set the stage, we're talking of food allergy as an immune system mediated adverse reaction to food. And if we detect systemic IgE, specific antibody to the food, this is classified as an IgE mediated. When there's no systemic IgE, this is referred to as a non-IG mediated and frequently associated with the gastrointestinal symptoms in isolation, such as food protein-induced enterocolitis syndrome or allergic proctocolitis or enteropathy and others. So we mentioned that food allergy, or Professor Vedantan mentioned that there's a lot of people affected by food allergies in the United States, and we usually think in terms of children, but actually the most recent estimates place adult food allergy as a more prevalent than children food allergy. So the study from the Center for Food Allergy Research in Chicago, led by Dr. Ruchi Gupta, where Dr. Niraj is also involved in, estimated that about 32 million of people in the US have food allergies, and this involves 10.8% of US adults, so it's 26 million, and 7.6% of children, which is about 5.6 million of the population. So those are really big numbers, indicating a huge burden on public health and truly unrecognized burden among adults. So this study that Dr. Gupta has performed was a cross-sectional study of US adults with surveys that were administered on internet and telephone between 2015 and 2016. So by now, we are a decade later, those estimates might be even higher. It involved a large number of US of adults, over 40,000, and the main outcome were self-reported food allergies that were considered convincing if symptoms to specific allergens were consistent with IG-mediated reactions. So that estimate only encompasses IG-mediated reactions. So as you can see, the shellfish was the most commonly reported trigger, followed specifically shrimp, but milk, peanut were really close to shellfish. To shrimp, up to 2% of adults reporting those symptoms, and tree nuts, finfish, wheat, and egg. Even more, twice as many believe that they had food allergy, but they did not have those immediate symptoms. And I think what is really striking is that 50% reported adult onset of food allergy. So this is something that was really not on our radar screen and definitely deserves further investigation. And furthermore, those are pretty significant conditions with close to 40% reported at least one emergency department visit for food allergy in their lifetime. And who is at risk to develop allergy in adulthood? Those are individuals that have comorbid conditions, atopic comorbid conditions such as asthma, atopic dermatitis, chronic hives, and this is in comparison to all survey respondents. And when you look at the specific sort of groups, you can see that there is as using white population as a reference, patients of non-white patients or multiracial patients, Asians, Hispanic, Blacks have higher increased odds of developing food allergies. The age groups, food allergies are mostly reported by females. The ages are mostly among the young, between 30 and 60 years old, It's rare to see food allergy reported over 60, new onset of food allergy over 60. Lower income ranges brackets compared to the higher income brackets, and Northeast and West, where compared to the Midwest, where had higher odds of developing a food allergy. And obviously, the atopic conditions that mentioned before were associated with higher odds of reported food allergy. So probably the most common Ig-mediated food allergy form in adults with adult onset is the pollen food allergy syndrome, PFAS. It's a contact urticaria to raw plant foods, fruits, vegetables, wheat, legumes, but also peanut and tree nuts. And this is due to cross-sensitization to homologous proteins in pollen, mostly PR10, profilins, lipid transfer proteins, but also gibberellins that were described more recently. It is usually associated with mild symptoms of contact urticaria, but about 10% may be having more systemic symptoms, nausea, vomiting, abdominal pain, or even hives, and less than 2% may progress to anaphylaxis. And it's considered a mild form of food allergy, of Ig-mediated food allergy, because patients tolerate processed, such as cooked, baked, pasteurized, or microwave forms of plant foods. And the management allows for ingestion of cooked, of those versions that are tolerated, with avoidance of the forms of foods that are actually causing symptoms. And this is just a representation of those common shared allergenic pan-allergens, such as BETV1 in birch, CORI1 in hazelnut, GLM4 in soy, and RH8 in peanut, that all represent pathogenesis-related family 10 of proteins. Food-dependent exercise-induced anaphylaxis is another form of food allergy that starts in adulthood. In contrast to pollen food allergy syndrome, it is potentially a severe anaphylactic reaction, and is characterized by the fact that food is tolerated in the absence of physical activity, with symptoms emerging only in the context of exercise. And exercise is typically quite vigorous, soccer, running, basketball playing, but for some people, even dancing or brisk walking may induce symptoms. The most common trigger is wheat, but other foods have been reported as cow's milk, shellfish, and celery. This is usually affecting young athletic individuals. So it was initially described in young athletic females, but I've seen teenage males also presenting with this form. And in particular, in wheat-dependent exercise-induced anaphylaxis, there's an association with omega-5 gliadin tri-A19 sensitization. So the management entails avoidance of food within 2 to 4 hours prior to exercise and 1 hour after exercise. There's rarely strict avoidance of the food necessary. Particularly, this may be relevant to people that are incredibly physically active, and it's impossible to really avoid find the safe time interval, carrying emergency medication, and definitely not exercising alone. And the mechanism is really unclear. There are physiologic changes. Exercise is a physiologic model of inflammation with increased release of certain pro-inflammatory cytokines, increased intestinal permeability, which is very transient. So this that subsides within 30 minutes to an hour after cessation of the exercise. So I want to move on to the pathways in food allergy that are associated with development of oral tolerance in intestinal mucosa. So oral tolerance is the default response to ingested food proteins. And food allergies occur only when this process of oral tolerance is disrupted. As I mentioned before, there may be a failure to develop oral tolerance, or there may be a breach in oral tolerance when we're dealing with new onset of food allergy in adults. And you're probably well familiar with the mechanism of oral tolerance in the intestinal mucosa, which entail IL-10 producing dendritic cells that lead to the suppression of Th2 effector cells, increased generation of RIC T cells, suppression of effector T cell migration to tissues, decreased production of IG by B cells, increased production of IG and IgG4, as well as suppression of basophil, eosinophil, and mast cell activation. As you mentioned before, being exposed to the food through a pathway that is non-ingestion, so through entry of allergen, not through the gut, may be associated with higher risk of IG sensitization. And this entails occupational exposure, such as handling seafood, and this is cutaneous exposure in the workers in the seafood industry, inhalation, and those are pathways specific to adults, especially those that have history of atopic dermatitis, because as we all know, atopic dermatitis is a risk factor to develop food allergy in childhood. Inhalation is also another possibility to food flours, egg, particularly in bakers, and soy and shellfish through also in the occupational setting. As I mentioned before, also pollen with secondary cross-reactivity to homologous plant proteins is a sensitization through the inhalation route that is followed by reactions upon ingestion. And also exposure to dust mites, cockroaches with secondary cross-reactivity to homologous shellfish tropomyocyns may be an example of that route. Also, tick bite induced IgE to alpha-gal in the alpha-gal syndrome. So there are many other infections, like viral infections, that potentially disrupt the microbiome and promote pro-inflammatory state in the gut, then also will lead to the breach of the oral tolerance. And when this happens, in particular for IG-mediated food allergy, this leads to the allergic sensitization, and then upon subsequent exposures, triggering of the classic effector cells such as mast cells, basophils, and production of the immediate reactions. If we are dealing with the non-IG mediated food allergies, there are T cells that are involved in the pathophysiology, and the reactions are usually delayed. So what are the risks of food allergy, particularly undiagnosed food allergy? Well, it's estimated that about up to half, so 50% of people who have food allergy are considered to be at high risk for anaphylaxis. And over the last several decades, food-induced anaphylaxis have requiring emergency room admission or hospitalization increased substantially. In the US, of course, there's data from US, every 3 minutes, food allergy results in emergency department visit, and anaphylactic food allergy reactions can be fatal. So immediate treatment is really critical. Just to illustrate that increasing prevalence for the emergency room visit, this is a nationwide emergency department sample, so population-based. You can see that since 2008 and up till 2016, there's a very steep increase, particularly in pediatric and young adult patient population, but also in all age groups up to 60 or 65 years old. This is definitely an objective measures because it includes of all sample of 20% of all emergency visits, representing a national estimate. And among anaphylaxis, so this is overall anaphylaxis, but you can see that from the same study, food was the most common identified trigger. Of course, the most common were unknown. So food was the most common, and followed by medication. And among foods, the peanut, tree nuts, and crustaceans were identified as the most common trigger. So anaphylaxis is really serious. As I mentioned before, food-dependent exercise-induced anaphylaxis is another possibility that can produce very serious reactions and associated with the intensity of exercise. And I want to highlight also this cofactor-dependent wheat allergy. So we always think about adult onset of wheat, or I used to think about adult onset of wheat allergy in the context of occupational exposure or exercise, but it turns out that wheat allergy may be cofactor dependent. So not only exercise, but other cofactors, which are known to decrease the trigger for anaphylaxis, such as intake of nonsteroidal anti-inflammatory drugs, alcohol, stress, infections, temperature extremes, and more recently also bariatric surgeries that that decreases the ability to digest the allergens. And really the adults who have wheat allergy cofactor dependent reactions are very severe, and the exercise is really a very common cofactor. The patients are adults are sensitive to omega-5 gliadin, and more rarely to the lipid transfer protein, which is tri-A14. But some patients were unable to identify the sensitization, and the reactions can be very severe. So when there's an adult with wheat anaphylaxis, omega-5 gliadin sensitization should be suspected. What is also striking that wheat reaction may occur in patients without atopic background and may be associated with severe cardiovascular symptoms. And then wheat-dependent exercise-induced anaphylaxis is a very common form of anaphylaxis. And those reactions can be atypical. And the authors of that study recommend evaluating patients with recurrent urticaria or idiopathic anaphylaxis to exclude wheat allergy, and particularly sensitization to omega-5 gliadin. And just to elaborate more about the wheat allergy, the classic wheat allergy sensitization occurs through GI tract, also with the wheat-dependent exercise-induced anaphylaxis. There are cofactors. And I also want to, we talked a little bit about Baker's allergy, where sensitization occurs through inhalation or potentially through cutaneous route. But also there's a entity reported from Japan when hydrolyzed wheat is included in some cosmetics, in facial soaps, has been reported in females in particular. And again, this is a breach of oral tolerance through cutaneous route. So wheat is really an interesting entity and allergen. I just want to touch upon alpha-gal syndrome, which is characterized by very delayed 3 to 6 hours IgE-mediated reactions, including anaphylaxis, so very serious, potentially anaphylactic symptoms occurring in the middle of the night. That can be traced back to ingestion of mammalian meat, beef, lamb, pork, but also gelatin candy and some dairy products. And this is caused by sensitization to disaccharide galactose alpha-1,3 galactose, for short alpha-gal. And it turns out that this is a sugar that is present in the bacteria, in the normal bacteria, in the component of the gut microbiota. And all humans have IgG and IgE antibodies against alpha-gal. But the alpha-gal syndrome is associated with the IgE sensitization to alpha-gal that follows bites from the ticks from Amblyomma genera, Ixodes, Hemaphysalis, and Drypicephalus. And I don't know if you have that entity in India. It has been reported from US, UK, Australia, South Africa. And this is really an emerging global allergic disease. And the saliva from the tick has alpha-gal carrying proteins, and the risk of IgE sensitization to alpha-gal increases with the number of ticks. Usually more than one tick bite is needed to induce IgE to alpha-gal. And also this natural history may be favorable because over time, without continued exposure to tick bites, this may wane. And I just want to touch upon anaphylaxis management. I just want to emphasize that epinephrine remains the first line of treatment in anaphylactic reactions. Usually it is administered through intramuscular route, but in the US, we now have new routes of delivery through intranasal epinephrine spray. And there are additional sublingual film that is in development and other forms of the intranasal, like powdered epinephrine. So it is potentially life-saving medication. And what we emphasize with the patients is, in addition to treating the symptoms of the allergic reaction by counteracting the symptoms, it also, if it's used early during the course of an allergic reaction, it will decrease the mediated release from mast cells and basophils. So that's why we really, and delayed administration of epinephrine is associated with worse outcomes, need for another dose or admission to the hospital, or even fatality. And of course, not using epinephrine is a risk factor for fatality. Just very briefly, if I have time, I want to talk to you also about non-IG mediated adult onset food allergies, such as eosinophilic esophagitis, which is characterized by symptoms of dysfunction, difficulty swallowing, and biopsy of esophagus that shows more than 15 eosinophils per high-powered field, and exclusion of other causes of eosinophil esophagealia. Epidemiology is an emerging disease of all ages, with increasing prevalence in the past 2 decades, with significant male predominance of 70%, with familial cases described in 7%, and current incidence of 5 to 10 per 100,000. And the prevalence of 0.5 to 1 per 1,000, and described on all ethnicities and all continents. In adults, the symptoms are mostly abdominal and chest pain, heartburn, dysphagia, as well as food impaction. And the management options include dietary management, pharmacotherapy, with biologic therapies being available in the US. We have swallowed PPI, swallowed corticosteroids, as well as currently dupilumab and emerging other biologics. And then surgical esophageal dilation remains the choice for managing patients with strictures of the esophagus, which may develop from fibrosis and chronic untreated inflammation. Another emerging condition is FPIES, or food protein-induced enterocolitis syndrome, which is a non-IG cell-mediated allergic disorder that can manifest with delayed symptoms of emesis or severe abdominal pain, starting with up to 6 hours after food ingestion. It may be associated with pallor, lethargy, diarrhea. In adults, the symptoms of severe abdominal pain are the most common. And this is really very dramatic, requiring pain medication. There's no typical skin or respiratory allergic symptoms. This is episodic, but this is no longer a rare condition. It's estimated 0.5% prevalence in a pediatric population in the US, and 0.22% of US adult population. And this is something that we think is becoming a more common occurrence, with the most common food triggers being crustaceans, fish, mollusks, but truly any food can cause it. And I had a patient with pea protein induced very severe FPIES reaction. So that dramatic severe abdominal pain, nausea, and vomiting up to 6 or even longer after ingestion, with a median age of onset about 25 years, with tolerance, with documented tolerance of the trigger food, with majority being female. So unlike eosinophilic esophagitis, here we are dealing with the female predominance, with significantly delayed diagnosis, with median 8 severe reactions before diagnosis is suspected. And the natural history is not well known, but this is probably a more persistent condition than the one from onset in childhood. And to date, we don't have known factors that are associated with the development of FPIES in adults. So in summary, the current estimate of adult food allergy are about 10.8% in the US, with higher rates among asthmatics, patients with eczema, chronic urticaria. About 50% of food allergic adults report adult onset food allergy, Risk factors of identified risk factors for adult onset food allergy include occupational exposure, atopic predisposition, infections, dysbiosis, which I really didn't have the time to talk about, as well as genetic predisposition. Food allergy is associated with the risk of acute reaction, including anaphylaxis, with increased emergency department utilization. I didn't really have the chance to talk much about the diagnosis or standard of care with dietary avoidance, but it is a big topic. So maybe in the future we can talk about this. So thank you very much for your attention, and I'm happy to take any questions.
Thank you, ma'am, for such an enlightening session. Thank you so much. Maybe we really would like to hear you further, as one of the questions which have popped up was, how do we go ahead with the diagnostic challenges between children and adult? Maybe next time we'll hear with you in that detail. Ma'am, there are a few questions. One of them is, what are the common food items which are responsible for adult food allergies?
So the most common ones are shellfish, shrimp, milk, and specifically peanut, and then wheat. So the wheat in particular, I would like to, like impress on you that, adults who present with idiopathic anaphylaxis or recurrent hives should be evaluated for wheat allergy. And, I don't, just keep in mind that I'm referring to adult population in the US. So local dietary patterns may have a big influence on that. So I don't know, maybe in India it will be lentils, or legumes in general, right? With high intake in the diet.
Ma'am, another question which is here is that since all exposures of these food items have occurred since childhood itself, why does the allergy precipitate only in adulthood? Means even as flour, even inhalational or cooking, there are exposures at home itself to all these cutaneous roots. People do handle food, eat, touch. Why does the body suddenly become allergic as an adult?
Well, I mean, we don't know for sure. Something leads to that breach of oral tolerance. And as you mentioned, there could be handling of foods and exposure through skin, especially if you're an atopic person who has, atopic dermatitis or has some kind of underlying, because a lot of people who outgrow atopic dermatitis, they still have an epithelial barrier dysfunction, right? So there's some kind of a defect in the skin. There may be inhalation, if you're cooking and you're inhaling, all of the fumes in the kitchen, this may lead to it. I definitely think that infections may be responsible. Hormonal changes through the lifetime. I think that this is not random, that females report more food allergies. It's totally unstudied, has not been investigated. But food allergy is an immune reaction. Our immune system changes all the time, right? Like we develop other immune-related diseases, which we haven't had when we were younger. So I think it's really important to understand that the food allergies or allergic conditions begin in the bone marrow. And it's just very incredibly dynamic and changes through lifetime.
Ma'am, there's one more question. In a proven case of wheat-dependent exercise-induced anaphylaxis, is it possible to have normal omega-5 gliadin serum IgE levels, which may increase on subsequent testing?
Yes, so it's possible, but also there are some patients who have reactions to wheat, and you cannot detect any known allergen. So omega-5 gliadin is really like a slam dunk, right? Like you find it, that wheat is the trigger, but a lot of the time, not a lot of time, but about 10%, so 1 in 10 patients that may react to wheat, that you actually don't see, you have negative tests. So clinical suspicion is very important. So it's the history taking, what was the food ingested within like 4 hours prior to that episode, really can help determine what is the trigger. And sometimes I didn't mention that, but in cases of patients with food-dependent exercise-induced anaphylaxis, sometimes you can elicit a history of food allergy in childhood. So there's, let's say, a child had a history of allergy to wheat as an infant, and outgrew it naturally, or milk, and then develop food. So there's some predisposition too.
And after the other question is primarily for wheat, ma'am. Wheat is a transient allergy and children outgrow it. Do adults also outgrow such exercise-induced anaphylaxis also? Do they outgrow, or even other food allergies for the matter? Is there an outgrowing or a tolerance which develops, ma'am, over time?
So it depends which allergy you're talking about. For the Ig-mediated food allergies, I mentioned alpha-gal, right? Like if you don't have that exposure, it will go away. For the like baker's asthma or like baker's wheat allergy in bakers, there's not a lot of information on natural history. I'm sure that some patients with avoidance, if you remove that exposure, they may outgrow, but it's usually a slow process. I can quote, for non-Ig mediated, for FBIs, only 30% would outgrow it over 3 years. So even with avoidance, it tends to be more persistent than in children. And, it sort of goes along with the notion that still in adults, the immune system is less plastic. There's no development, right? Like there's no natural development of tolerance or carrying at this age. So it may be more persistent, although there will be patients who will be able to resume. And that therefore, periodic reevaluation is indicated.
Ma'am, one more question. Vedantan sir has asked, are you seeing milk allergy in adults also, ma'am?
Yes. So milk allergy is actually one of the most common triggers. And we're not talking about lactose intolerance. We're talking about people having hives or anaphylaxis, within 1 to 2 hours after eating the food. So, and it can be very severe. And as you know, milk allergy is a very, well, it's incredible. If it's severe, this is a very, very difficult, potentially life-threatening food allergy that really changes the quality of life of the person, because it's so impossible. I mean, it's so difficult to avoid milk in the Western diet. So absolutely, milk is a again emerging, I would say emerging trigger for anaphylaxis, but also obviously for the non-IgE, like for eosinophilic esophagitis or for FBIs. Also, adults can start developing symptoms.
Thank you, ma'am. I
Thank
think
you.
with that, my questions are over. Thank you so much. We
Thank you
hope to
for
listen to
having
you
me.
again, ma'am. Thank you.
Thank you.
Thank you so
Bye-bye.
much.
Congratulations on
Bye-bye.
symposium. Okay.
Thank you, Anna. Thank you very much. Thank you.
We shall now proceed to our next session, which is by Professor P.K. Vedantan, a distinguished allergist and immunologist from University of Colorado, USA. Sir has numerous distinguished publications and research activities in his name. Sir, with great pleasure, I call upon you to deliver the talk on differentiating food allergy from food intolerances and other mimics. Over to you, sir.
Thank you so much. Appreciate your invite to participate for me. And I just want to see how can is the slide, are you able to see the slide?
I can see part of it, sir. So I think it's on the presenter screen, sir. You put it, I think the
Is it okay
slideshow
now?
once you go to... yes, sir, it's okay now, but it's a little big.
Okay. Thank
Neeraj,
you very
sir,
much.
can you see it? Sir, 1 minute, sir. Yes, sir, it's okay, sir. It's fine.
Slides are
Right.
good. Please
Thank you, sir. Please proceed. Thank you.
Thank you so much. It was a very enlightening talk about adult food allergy. So we really have to get history about food allergy in adults from now on because it is actually accelerating quite fast according to the previous speaker. My job today is actually quite simple. How do you differentiate food allergy from conditions that mimic food allergy? So what I have done is I have made this a very clinically oriented talk. Actually, couple of cases are from my own family, including myself. So it was not that difficult for me to write up this presentation, because 3 of these cases that I have here are in my own family. So let's go on. This is an enigma. There is nothing like food allergy in the field of allergy, because this is a type of allergy which appears and disappears on its own. I don't know why food allergy gets better as the child gets older, like milk allergy, wheat allergy, soy allergy, they all seem to get better, wheat allergy. So, but some allergies continue to get worse and they persist. So, this is an enigma. Why is food allergy getting better? Why is food allergy persisting? Something we really have to explore. And also, this type of picture leads to a dynamism. This is a dynamic field of allergy, including surgeons are interested now. I was just recently ran into a cardiothoracic surgeon who started talking about food allergy. So this means this is a topic that not only health professionals are interested, general public are interested, and the different specialties are interested in this field. And other thing that has happened is what all we were telling our patients to do or not to do, we are telling opposite now. We used to say avoid, now we say introduce. And so several foods. So these parameters, if you look at practice parameters about 20 years ago and compare it now, 180 degrees change, because for good reasons. That means we are really making some progress in the field. At the same time, our environment has changed also. The way we live has changed. And all these factors have influenced the evolution and propagation of food allergy. Now, my job here today is to only look at certain obstacles in the proper diagnosis of food allergy. One of the obstacles is using a wrong terminology. Say for food allergy, when I say a word food allergy, I mean it as an immunological response. It's an abnormal immunological response. As the previous speakers beautifully had a very nice slide which showed IgE mediated, non-IgE mediated, or a mixture. So it is, but it has to be an immunological response. That is what food allergy is. Whereas a non-immunological response may be due to many other reasons. It could be toxins, infections, metabolic. We'll just look at that. Now, which is more common? Is it intolerance or food allergy? Obvious, definitely food intolerance. 90% of the cases that you see are due to non-immunological reactions. They are not food allergies. Food allergy constitutes only, in India, it is extremely low, less than 1% in India. In some countries like Australia, where they have done some incredibly good studies, health nut studies, it has been reported almost 10 to 12%. So it can vary from 0.1% to 10%, depending upon whom you are quoting. But 80 to 90% of the reactions are non-immunologic. So to cover all this type of reactions, we use a word called adverse food reaction, which is an umbrella term. Now, as far as the public is concerned, everything is an allergy. If public perception of food allergy is extremely different, we will look at that in a minute. Now, classification, I'm not going to go through this whole slide. Basically, immunologic or non-immunologic. Yeah, under immunologic, IgE mediated, non-IgE mediated, or it could be mixed. Or IgE mediated, we are very familiar with these typical IgE mediated immediate reactions with temporal relationship. Then we have another broad non-IgE mediated where we don't know what mechanism it is. It is mostly due to intolerance, but there seems to be some immunological factors. Or you have a mixed issues like we have this atopic dermatitis. It's a very difficult disease. Or eosinophilic esophagitis, which the next speaker, Dr. Vinay, is going to address very well. So then we have non-immunologic, which we run into issues almost every week we will see something like this, where somebody is lactose intolerant or having side effects due to certain alcohol or caffeine products or certain food products or due to insufficiency of certain enzymes. So they are all lumped under what we call as a non-immunological thing. So when you want to diagnose food allergy, you need to go with an open mind and approach the patient, not having a, an inborn, having a sort of an impression, it is food allergy. Don't go with that impression. Go with an open mind. Let us see what the patient has to say. And then we will see what type of reaction that it is going to sort of fall under, whether it's food allergy or more of an intolerance or what. So for us, as I just mentioned to you, just looking at this whole thing closely, it's a little bit repetitious type of slide, but basically the salient clinical manifestations of food allergy is this temporal relationship. Within a few minutes or within 2 hours, you will have a reaction. But most important part of food allergy is the mast cell activation. I'm going to show you the next slide very briefly, which shows a significant release of histamine is occurring due to the mast cell degranulation due to IgE antibody and the antigen reaction. And the manifestations of typical food allergy is 80% of the time is dermal. When the patient has taken a particular food and is truly allergic, first thing he feels is, I feel hot. Patient says, I feel hot. I feel itchy. And this is manifestation of histamine release. Histamine release, very important. And then they start having hives, or then they can have respiratory symptoms, or it could be, then it can lead to cardiovascular collapse, depending upon the intensity of the reactions and at what rate it is occurring, how early is it occurring. All these are all factors we need to be aware of. So this slide is showing you the mechanism, but basically there are two aspects to it. One is sensitization, another re-exposure. Sensitization, where you already have a preformed IgE against that particular food because of the T cell and B cell interaction. And the re-exposure causes a mast cell degranulation due to the coupling reaction between the allergen, which could be the food item, and the specific IgE on the surface of the mast cell. And all of you are extremely familiar with this mechanism, so I'm not going to go through. This is what happens in a typical food allergy that we have to address. Now let's go a couple of case scenarios. Number one, 24-year-old developed abdominal discomfort, bloating sensation within 30 minutes after ingestion of glass of cow's milk. Is this allergy? He does not have any skin symptoms. And there is some temporal relationship. Temporal relationship is the time of onset of symptoms after the episode. He is having symptoms within 30 minutes. Okay. Now, to me, it sounds like a lactose intolerance. Lactase is an enzyme that we all produce. It's in the intestines. It is right in the small intestines on the microvilli. And these symptoms do not develop immediately. It takes another 30 minutes to almost 1 hour, 2 hours sometimes. And the lactose is converted into galactose and glucose in our gut. And that is how it is absorbed. But in some people, the lactase enzyme is deficient, and your intestines cannot directly digest the lactose, which is in the cow's milk or any other milk product. And that causes the very, very uncomfortable situation of bloating sensation and nausea, sometimes occasionally vomiting. And so this diagnosis here is not an allergy. There is no evidence of mast cell activation, no history of any feeling hot or breaking out or anything like that. This sounds like a lactase deficiency. Now, a few words. Which product has the most lactose that we run into is whole milk. Whole milk has almost 8 ounces of it, has almost 12 to 14 grams of lactose. Whereas certain foods like cheese, Swiss cheese, cheddar cheese, or what they call as cottage cheese, they all have a lot less. There could be like 10 times less than the whole milk. So these people, they may not have complete absence of lactase, but they will have deficient lactase. So they probably can handle certain substitutes where they could use certain milk products which are low in lactose content. So you need to look it up and tell them. Another important thing is these patients have to look at labels, like bread has milk in it, cookies have milk in it. So there are so many products that have got milk products. So you have to look at the labeling. And that is lactase deficiency. Treatment is quite simple. You just have to supplement with lactase enzyme, and that will handle the situation. You take it with food. And how common is it? It's quite common. Practically almost all of us must have experienced it, because there are 3 types of lactase deficiency. One is primary, which is not that common, but that means right from birth there is some lowering, less of this enzyme can persist into adulthood, and that is no reason is found. The other one is secondary, which is the one that is much more common just due to a simple antibiotic usage or any type of procedures, or even comorbid conditions like diabetes, and all those things can cause lactase deficiency, secondary lactase deficiency. There's also a congenital lactase deficiency. Next case, 45-year-old female, symptoms of chronic rhinitis with partial anosmia, has nasal symptoms which is not particularly responsive to intranasal steroids. See, these are very important sentences. Anosmia, partial anosmia, chronic rhinitis. So you should always start thinking about certain things. This doesn't sound like a typical allergy. You do not get anosmia in allergy. And you also have we know that intranasal steroids are extremely effective against inflammatory rhinitis. Either it's allergic or non-allergic, but this lady is not responding. So there must be a reason. Then third thing, she also has a significant flare-up of her symptoms within 15 minutes after ingestion of wine. Then she thinks, oh, I must be allergic to alcohol. So our way of thinking should be, this is a patient with chronic rhinitis, partial anosmia. So I am already thinking about non-steroidal respiratory disease. Okay. So this could be NSAID, ERD, and so like a triad. And this patient, and she's a female, 45-year-old, and typically these patients have an incredible intolerance to alcohol. Alcohol ingestion has been shown to increase the leukotriene content in your system, and they have measured the urinary LTE4, and increases in significantly in these patients. So this patient has an outpouring of leukotrienes, and so it is a metabolic disorder. It is a disorder in the arachidonic cycle, and this is a case of early case of NSAID ERD, and this is a metabolic problem. It is not an allergic problem. She's not allergic to alcohol, but she's actually has a metabolic problem. And one of the things that makes you suspicious is because of the outpouring of pro-inflammatory mediators. These patients do not respond to inhaled steroids. So if you have a patient with rhinitis who does not show that good a response to intranasal steroids, always think about this condition. Or someone who has a history of significant upper airway or lower airway or both symptoms with alcohol ingestion. It's just simple wine, a beer can do this. Always think about this condition. It is not an allergy. It's a metabolic problem. Third patient. 24-year-old, otherwise very healthy lady. She's one of my patients actually. Sensation of heat, itching, erythematous rash developed into hives within 10 minutes after ingestion of salmon fish in a restaurant where she was eating. and she also started having scratchy throat and coughing. I eliminated the rest of the history because she went ahead and got appropriate treatment and got better. Then I saw her. Is this allergy? Yes, it is allergy because it is causing, it has a definite temporal relationship. Patient is reacting in 2 minutes, and she's having these symptoms that are uh, consistent with uh, mast cell activation with release of histamine and causing this triple response where she is having a significant erythema and also itching and respiratory and dermal symptoms. So she was then found definitely sensitive to salad. This is a typical food allergy where you have a temporal relationship, mast cell activation, and has these acute symptoms of the histamine release phenomena. Now, another case. 24-year-old doctor served with a type of brinjal unknowingly at lunch. He has a history of allergy to brinjal for several years. He thinks his allergy is actually a doctor, and for several years, and also dislike for this item. His fiance's mom served him the same preparation without revealing the contents, and actually he took it twice. He did not develop any symptoms, and he wanted it more. He was not surprised when he was told what actually he had consumed. Is this allergy? Yes, definitely no. This is not allergy. What it is this doctor, actually, that was myself. I had an aversion to this type of brinjal. I thought this would bother me, but unknowingly, I was served with the same dish and I enjoyed it. So, what I had was more of a psychological issue. I had this food aversion. So this is not food allergy, but I thought it was food allergy, even being a health professional. 16-year-old sandwich, he had sandwich with wheat bread, cheese, tomato, mayonnaise, which has got eggs in it, and went for a jogging. In 10 minutes she started feeling woozy, developed itching, hives, flushing, laid down on the ground, and a friend was right there who dialed for emergency. Is this? Yes, it is exercise induced anaphylaxis. Exact um, mechanism is not completely figured out, but there is a definite mast cell release of histamine, and all these pro-inflammatory mediators can be a significant problem, and they will respond quite well to EpiPen, antihistamines, the usual treatment, and there is a definite temporal relationship. Somehow, these patients do not react if they eat that particular food alone or if they exert alone without taking that food. So we tell these patients not to eat or consume any of these type of foods 3 hours before, 3 hours after. So this combination of food and exercise seems to bring on this very significant condition called exercise induced anaphylaxis. Yes, it is an allergic problem. You could go ahead and skin test or evaluate her for allergies. You may find that this person may have sensitization to different foods, and probably could be some inhalants also. 6-week-old child, another case scenario 6-week-old infant, product of full-term delivery, birth weight good, pretty good, physical exam perfectly fine, mom is healthy, consuming milk, but the thing which is brought this child to us is passing of bloody stools. Blood in the stools is very scary to the parents as well as to rest of the family, including some physicians also. Is this an allergy? This does not this is what we call as food protein of a FPICE intolerance. FPICE is a it is sort of it is not an allergy condition. Exact mechanism is not known. There is no evidence of mast cell activation.
I think Dr. Vedantan sir has accidentally logged out.
Okay, sir.
So, Dr. Soundarya, can we start with Dr. Mehta's talk now?
Okay, sir. We'll proceed, sir. We'll continue Vedantan sir's talk later. Hi, Dr. Vinay. Such a pleasure to have you. Just a minute, sir. I'm logged in through 2 devices, so I'm echoing. So we now, because Dr. Vedanta could not be there, we'll now begin with Dr. Vinay Mehta's talk. Dr. Vinay Mehta is a renowned allergist and immunologist at Nebraska, USA, with numerous publications to his name. Sir is also a faculty at the Pediatric Allergy Program, DPA and DA in India. So with great pleasure, I now call upon Dr. Vinay Mehta to kindly proceed with his talk on eosinophilic esophagitis, diagnosis and management for clinicians. Over to you, sir.
Okay, good evening and thank you, everyone. And hopefully we'll get Dr. PK back soon. So what I want to do is in the next 20 minutes, really give you a nutshell of the diagnosis and management of eosinophilic esophagitis. This is a disease that we once thought was relatively rare. Now we know that it is actually much more common. So I think you need to be aware about a little bit about the disease, what it is, and then more importantly, as an allergist, how do you make the diagnosis and how do you manage the disease? And also how do you manage or co-manage with the gastroenterologist? So we'll talk about that. And if you have questions, please let me know. So first, definition. So what is eosinophilic esophagitis? So like most atopic disorders, it's a chronic disease. It's a chronic immune antigen-mediated disease, means you do have antibodies involved. But as we will see, it is not classic IgE-mediated disease. Okay, it's followed between IgE and non-IgE mediated. And it's a disorder of the esophagus. So clinically, it's characterized by esophageal dysfunction, typically trouble swallowing, pain upon swallowing, nausea. Those are the classic symptoms, and histologically by eosinophil predominant inflammation. So when you do biopsies from the esophagus, if you see more than 15 eosinophils per high power field, that is diagnostic. And EoE is certainly one of the possibilities. Now, this condition is isolated to the esophagus alone. And as in other disease, there's a differential diagnosis. So you have to rule out other causes of esophageal eosinophilia. And just to remind you, for those of you who are not familiar, normally in the esophagus, you should see 0 eosinophils. The esophagus is devoid of eosinophils. But as you go down in the stomach, okay, in the gastric antrum, you may see about 10 eosinophils per half power field. As you move further along, now into the gut, in the duodenum, it's normal to see up to 20 to 30 eosinophils per high power field. And in the colon, you have a lot more. And as you know, the eosinophils, they're there to protect you as part of the innate immune system, and they also are there to protect you from parasites. So it's normal to see a lot of eosinophils in the lower tract intestine, but not in the esophagus. And so how common is it? Well, it's about 1 to 2,000 in Western countries. Unfortunately, in India, we don't have much data. It's probably also under-recognized in India, but I would say in general, it's at least 1 to 2,000 individuals. Most of the time it occurs early in life, just like most atopic disorders. There is a male predominance, about 3 to 1. And when you look at different studies, in patients who have undergone endoscopy for any reason, it's about 5%. So 5% of patients undergoing endoscopy have EoE. But if you have symptoms of dysphagia and then you go get an endoscopy, it's much higher. It's about 12, 23%. And it is the most common cause of a food impaction. So food impaction is when you completely can't swallow. You have to regurgitate your food bolus. So when you see a food impaction, it's probably EoE until proven otherwise. And just like other allergic disorders, there are oftentimes you'll see comorbid atopic disorders in most patients. So EoE does not occur in a vacuum. Okay, so when should you suspect EoE? These are patients who most of the time have allergic rhinitis. They may have asthma. They may have atopic dermatitis. They may have a true food allergy where they actually get anaphylaxis to the food. And then about a third will have oral allergy syndrome, which is when you eat certain fresh fruit or vegetable that cross-reacts with one of the pollens such as birch or ragweed or grass pollen, and it causes oral pruritus. So we see that in about a third of individuals. So this is the population where you really have to hone in on and inquire, could this patient also have EoE? And then there are also non-atopic conditions associated with EoE. So half the people with EoE also have reflux. In children, oftentimes, this is part of the differential. We see children who have failure to thrive. So EoE could be the reason. We see this sometimes in autoimmune disease, and then more rarely in celiac disease, 2%. And it's also increases the risk of inflammatory bowel disease. It's about a 3.5% risk. And then depression. People with EoE can get psychiatric comorbidities, especially depression. And so it's important to understand that this is a progressive disease, and so the signs and symptoms vary. Okay, the presentation in children is very different from the presentation in adults. In children, oftentimes you'll get reflux-like symptoms that don't respond to antacids. You may get nausea, vomiting, abdominal pain. The child may refuse food, and so as a result, failure to thrive. And as the disease progresses, as a child gets older, in adolescents and adults, that's when food starts sticking. They have trouble swallowing. They may get pain when they swallow. And so the disease starts out inflammatory, but as the disease progresses and there's remodeling of the esophageal wall, and you get fibrosis, you have more dysphagia symptoms. So it's important to be aware of this. Moreover, many patients will adapt. They develop adaptive behaviors in order to compensate. So they'll imbibe, every time they eat, they'll make sure they flush it down with lots of fluids. They may cut their foods into small pieces. Oftentimes they're considered slow eaters because they take their time. They chew excessively. They deliberately avoid hard texture foods. And they don't swallow pills. Pills and tablets, they chew them instead of swallowing them. So these are all adaptive behaviors which children and adolescents learn over time. And so it's really important to be aware of that. So getting to the diagnosis. So first, history is very important. Ellie mentioned that's the first thing you want to do. And when you have someone you suspect may have EoE, you then send them to a gastroenterologist, either a pediatric gastroenterologist or an adult gastroenterologist. Ask them to do an endoscopy. Ask them to do biopsies. That is very important. We recommend at least 6 biopsies from the esophagus, at least 3 from the proximal esophagus, 3 from the distal esophagus, and then you want the gastroenterologist to send to a pathologist where they actually count. You need to count how many eosinophils per high power field, and the threshold is 15. Now, that does not necessarily mean that you have EoE, but that means that, you could have EoE. So you do have to rule out other causes. So what are the other causes? Well, it could be, severe reflux can sometimes look like EoE. You can have other eosinophilic gastrointestinal diseases where it's not just the esophagus, but you may have involvement of the stomach and the duodenum. More rarely, rare conditions like hypereosinophilic syndrome, connective tissue disease, Crohn's disease. Remember, Crohn's disease can be patchy. It can have involvement of the esophagus. Certain infections can cause inflammation of the esophagus. And then there's a condition called pill-induced esophagitis. Drugs like doxycycline can cause mechanical and chemical irritation of the esophagus. So you may have some transient eosinophilia in the esophagus. So this is part of the differential. Now, sometimes the esophagus can look completely normal in up to 30% of cases. And that's why it's important to tell the gastroenterologist, please get biopsies, even if it looks totally normal. And if you suspect eosinophilic gastrointestinal disorder, meaning involvement of the stomach, involvement of the duodenum, please ask the gastroenterologist to take additional biopsies. From both the stomach and the duodenum, because that's important as well. All right, so what causes EoE? Well, like most atopic disorders, we don't have a full understanding, but we know that there are 3 pillars. There's a genetic predisposition. So you are born with certain genes, you are predisposed to for a T2 phenotype. Then you have the environment. And when I say environment, it means we're talking about environment allergens and food allergens. And then number 3, you have an exaggerated T2 inflammatory response. Okay, so EoE is a T2 mediated disease characterized by infiltration of eosinophils into the esophagus. And so here again, genetics play a role, environment plays a role, and the host immune response plays a role. The cytokines involved are IL-4, IL-5, IL-13, and that's what drives the inflammation. That's what drives the eosinophils to get into the esophagus. Remember that in the normal esophagus, you should see 0 eosinophils. So how does this happen? Well, think of it like atopic dermatitis. So similar to atopic dermatitis, it is a barrier disease dysfunction. So what happens is when you have esophagus, let's see, this is the esophageal wall, where we have epithelial cells. And when you have a disruption of the barrier, it allows antigens, both food antigens and aeroallergen antigens, to penetrate through the epithelium. This causes the epithelium to release alarmins. These are danger signals, IL-4, IL-5, IL-13. Probably the most important is IL-13. IL-13 can actually stimulate eotaxin, which is a chemoattractant for eosinophils. So now you have eosinophils that can get into the tissue. We know that IL-5 is a chief growth factor for eosinophils from the bone marrow. So IL-5 production will upregulate production and activation of eosinophils. And then IL-13, by the way, IL-13 actually upregulates this enzyme called calpain-14, which is a enzyme specific to the esophagus. And what it does when you upregulate this enzyme is it causes loss of desmoglein, which is a part of the cell-cell junction. And so it further disrupts the esophageal barrier. And so this is it's an ongoing process. Once it starts, it's difficult to control. And so what is your role as an allergist? Well, I think first you have to, help make a diagnosis, but you also have to evaluate for other atopic conditions because most of the time EoE doesn't occur in a vacuum. You also have to co-manage the disease with a gastroenterologist. One thing that is new in EoEs is we don't recommend allergy testing to foods, to screen for trigger foods. That used to be the case many years ago. Now it is not recommended. But we do recommend testing for environmental allergens because there's a high prevalence, with allergic rhinitis and asthma. So I definitely recommend checking for environmental allergens. And then your treatment goals is you want to treat symptoms, so you want symptomatic resolution, but you also want histological resolution. Just because the patient feels better doesn't mean that their disease is gone. So at some point they should have a repeat endoscopy. And also the endoscopy should look normal. There are some characteristic changes that you can see on endoscopy with EoE, and you want those to be gone. But it is a chronic disease. It does require long-term management, just like asthma, just like allergic rhinitis, just like atopic dermatitis. And so this is the treatment algorithm. This was updated earlier this year in January. And I'm going to go over each of the parts. But the main message here is that it is both inflammatory and a potentially fibrostenotic disease. And so the first thing you want to do or can do is, if you go down the algorithm, is first diet elimination. And what that means, we know that certain foods can be trigger foods for EoE, especially milk. And so the goal of dietary elimination is you eliminate certain foods. Hopefully this will reduce inflammation in the esophagus. And this is a it's a non-pharmacological alternative and can be used, especially in children. If parents are leery about swallowed steroids, you can offer this. It does work. And what we do, the most strict elimination diet is the amino acid diet, which is done very rarely. That is maybe done only, very short term if you really have severe disease, maybe about a month maximum. But then you transition them to what's called empiric elimination diet. So this is not based on skin testing. This is an empiric elimination diet. You either eliminate one food, which is milk, or two foods, which is milk and wheat, or 4 foods or 6 foods. Now, there is one caveat, and this data is based on Western data, so this may not be applicable to the population in India, but this is, this is what we use, and it is pretty effective. So just eliminating cow's milk itself gives you about 50% response histologically. It's almost as good as eliminating 6 foods. And so what I personally do in my practice, I just tell the parents, please cut out milk in the child's diet. That alone, there's about 50% response rate. It's actually interesting that, the response rate for empiric elimination diet is actually higher than if you did allergy-directed food elimination diet. So, it's about, 10 years ago, what we used to do is we used to do skin test to a bunch of foods, and the foods that were positive, we used to tell parents, okay, just eliminate those foods. But it turned out that actually is a wrong strategy, whereas just empirically eliminating even just milk alone is equal or not even, or even better than allergy-directed food elimination diet. Now, once you eliminate food, obviously whether it's 1 food, 2 foods, 4 foods, 6 foods, what you can do is then gradually you can reintroduce the food back into the diet, but that will require rescoping, which may or may not be practical. But ideally, when you eliminate the food, you want to see if you can. First, you want to see if it improves. So you want to get a repeat endoscopy with biopsies. If it's normal, then that's great. And then eventually, you want to see if you can introduce back the food in the diet. And so you introduce a single food in the diet, rescope, and if the endoscopy still looks normal, then that's great. So you can step up, you can step down. This is how you monitor histologically remission. Okay, so that is elimination diet. The second thing is now pharmacotherapy, and this is something that we typically start out with. I certainly start out with this. This is PPI therapy. It's very inexpensive, it's effective, and PPI therapy alone can induce remission in about 42 to 50% of patients. It's important to understand that this has nothing to do with acid. PPI therapy itself can reduce eotaxin-3 secretion. It can help improve the esophageal barrier function. So we're not trying to suppress acid. Now, if the patient also has reflux, which 50% of children do, then that's great. It also will suppress acid, but this is primarily eotaxin-3. And the typical dose is twice the standard dose. You do it for 8 weeks, and if the patient does well, then you can wean off and taper down to the lowest effective dose. So that's PPI therapy. The second thing is swallowed topical corticosteroids. We know that steroids will suppress eosinophilia. They also help reduce fibrosis and remodeling. There are 2 steroids that we commonly use, fluticasone and budesonide, and studies have shown improvement in early as 8 weeks. That being said, if you have significant narrowing, so if you have fibrotic disease, then you're not going to respond as well to topical corticosteroids. You may need something additional. This was a meta-analysis. This was done in both adults and children. As you can see, just swallowed fluticasone by itself, there's about a 2/3 response rate in terms of inducing remission, histological remission. You have a high response rate with swallowed budesonide, about 77%. Now, because you're swallowing the steroids, there is a risk of developing thrush, either esophageal candidiasis or esophageal candidiasis. This unfortunately can occur in about 10%. Plus, because you're swallowing the steroid, okay, unlike in asthma where you're inhaling the steroid, here you're actually swallowing the steroid, so HP axis suppression can occur, especially in children. How do you dose it and how do you deliver it? Well, to dose it, because you're swallowing it, what you do with fluticasone is you take the canister, you put it in your mouth, and as you push the canister, you ask the child to swallow it. Okay, so they're not inhaling, you're deliberately asking them to swallow the steroid and then have them rinse with their mouth to at least try to reduce the risk of oropharyngeal candidiasis. If you're using budesonide, well, you can't just drink the budesonide straight. You have to mix it. You have to mix it with either a sweetener or sugar in order to create viscosity, because you want the steroid to stick to the esophagus. So typically you take your budesonide and you mix it with sugar or Splenda or honey, and then you swallow it. And then in both cases, you don't eat or drink for about 30 minutes. The idea here is you want the steroid to stick to the esophagus, and so you don't want to eat or drink for about 30 minutes. Now, the response rate is great. The only problem is what happens when you stop, and unfortunately, there is a high relapse rate when treatment is discontinued. Now, assuming that, let me go back on the algorithm here. So I'm assuming that, you've tried diet elimination, you tried pharmacotherapy, both PPI and topical corticosteroids, but let's say if you have a fibrotic disease, let's say if there's significant narrowing, there's a stricture, and it doesn't respond to either of the treatments. In this case, the endoscopist, so not you, but this will be the gastroenterologist, they may have to dilate. And so what they do is they go in, they try to dilate. The goal is to try to dilate so that the esophageal lumen is about 16 to 18 millimeters. But it's important to note that this alone will not treat the disease. It's a little bit like the cardiologist that puts a stent. The stent alone will temporarily alleviate symptoms, but long-term disease is going to come back because dilating the esophagus has no anti-inflammatory properties. So you have to use this in combination with diet or pharmacotherapy. Also, I want to note that there is a risk of rupturing the esophagus every time you try to dilate. And so you want to be careful how many times you subject the child to dilatation. And so finally, we come to dupilumab, which is a biologic. I might believe it is now available in India, approved for atopic dermatitis, but it's also been shown to be useful in EoE. Just to remind the audience, dupilumab is a monoclonal antibody that blocks IL-4 and IL-13 signaling. If you recall, IL-13 signaling is critical in mediating EoE. And so when to use dupilumab? Well, in patients who are refractory to topical corticosteroids or who have topical corticosteroid intolerance. In those people where you really don't want to, they've had side effects from steroids, or they don't respond to topical corticosteroids, or if they have many other conditions, not just EoE, but they may have asthma, they may have atopic dermatitis. So in this case, using one drug, being able to treat multiple pulmonary diseases can make sense. And so the trials have been done both in adults and children. I myself actually was involved in some of these trials. This is called Liberty EoE Treat. This was a 3-part trial where we took patients 12 years and older who had EoE, who did not respond to PPI therapy. Also, about 70% of them had been on swallowed corticosteroids, didn't really respond. And so what we did is we randomized these adults to 3 arms, either dupilumab 300 milligrams every 2 weeks, 300 milligrams weekly, or placebo. And at 24 weeks, we measured their histological response. We also measured their response in terms of symptom control, symptom improvement, namely dysphagia. So were they able to swallow now? So this was a 3-part study. You had part A, part B. In part A, there were just two arms. In part B, there were 3 arms, so 2 different doses. And then after 24 weeks, we put them into an extension trial. Those who got placebo were re-randomized to active treatment. Those who were already on active treatment remained on active treatment, and this was done for an additional 24 weeks. So this was a 52-week trial in total. And so these are the results. So part A, part B, those were looking at 24 weeks, dupilumab versus placebo. And what you can see is a very, very high response rates. About 60% in both arms by week 24 had histological remission. And what that definition of histological remission is eosinophils less than 6 per high power field. So that is a very, very high bar, very stringent bar to achieve. And indeed, both the weekly dupilumab as well as the every other week dupilumab arm achieved that high bar. And this was maintained, throughout the 52-week period. So those who had previously been on placebo, once they got on dupilumab, you can see that those patients also responded. About 60% went to histological remission. Now, in terms of swallowing improvement, here you can see that in the weekly arm, there was significant improvement in the dysphagia symptom questionnaire score, which meant these patients could now swallow. But in the every 2-week arm, it actually didn't achieve significance compared to placebo. And so that's why for adults, at least for patients 12 and older, the dosing is 300 milligrams every week. All right, so just to summarize, as I mentioned before, EoE is a chronic disease. It's an immune antigen-mediated disease of the esophagus, characterized clinically by esophageal dysfunction, means mainly trouble swallowing. It could be nausea, vomiting. It could be pain upon swallowing. It could be failure to thrive. And then histologically by eosinophilia. So more than 15 eosinophils per high power field. Pathogenesis is uncompletely understood, but involves genetics, environment, and post-immune response, just like most other atopic disorders. Food allergy testing, which we used to do in the past, is no longer recommended to identify EoE triggers. The goal of treatment is to achieve both clinical and histological remission, not just short-term, but long-term. So in terms of our therapies, first-line therapies would include diet elimination. It would include PPI therapy. It would include swallow topical corticosteroids. You can do this by itself, or you can combine several treatments. And those who are not responsive to these treatments, you may want to consider dupilumab once once it's available and once it's affordable. I know cost is certainly an issue that in India you have to consider. And then as an allergist, your role is to play a pivotal role in the co-management of not only EoE, but also its associated atopic conditions. So thank you very much. Incidentally, for those of you who don't know, I myself have EoE, and so that's why I have a very vested interest in this disorder. So thank you very much.
Thank you, sir, for that lovely session. Sir, there are two questions.
Yes.
Milk and wheat are the top two foods to be avoided in children with eosinophilic esophagitis.
Yes.
Which such one or two food items are there which should be avoided in adult onset eosinophilic esophagitis?
We use the same foods, so there's not much difference. And in fact, I would recommend even just milk alone. No need to do milk and wheat. One of the things that you also have to, especially in India, you have to consider there may be nutritional deficiencies. So if you try to eliminate too many foods may actually be detrimental. So knowing that there's not much difference between single food and even 6-food elimination diet, I have changed the way I practice. And right now, the only thing I tell people, both children and adults, just stay away from milk.
Thank you, sir. And one more, if a patient is having a history of allergic rhinitis or asthma and now has eosinophilic esophagitis, is it possible that a common allergen like dust mite or any other aeroallergen is responsible for both? Or are they separate entities where the eosinophilic esophagitis is due to food allergy and the respiratory symptoms are because of other aeroallergens?
Yeah. So EoE can be triggered by food antigens, such as milk, wheat, but it can also there's increasing evidence that aeroallergens can also trigger EoE. I'll give you my example, and this is just anecdotal, but in my example, I put myself on immunotherapy for aeroallergens and my EoE got better. So it's not part of the guidelines. I would never tell the patient, or the parent that I'm going to put your child on allergy shots and you can't guarantee that their EoE will get better. But there are many case reports where it has gotten better. So certainly that's one of the treatments which is not mentioned in the treatment algorithm because it's not part of the official guidelines. But if you do have concomitant allergic rhinitis, concomitant asthma, you can say, let's try immunotherapy, and it may improve your EoE as well.
So there's another one last question. Are there any other causes that we should consider when we have eosinophilia in the esophageal biopsy, like GERD or giardiasis? That's what they've written. So
Yeah.
is there any other cause, or it's already just diagnostic of
No,
EoE only?
no. There's a differential. So reflux, certainly. So that's why the other what you want to do ideally is not just take one biopsy, and not just take a biopsy in one section, because reflux alone can cause eosinophilia, but generally it will be limited to just the distal esophagus. And generally with reflux, you'll see less than 15, but in some cases you may see 15. So number one is try to get as many biopsies as possible, at least 6 in different locations. We know that in the differential, reflux is certainly can occur. So reflux is definitely, yes, infections, and yes, parasitic infections can certainly cause eosinophilia. I mentioned pill-induced esophagitis, which we see with antibiotics like doxycycline. More rare cases, inflammatory bowel disease like Crohn's disease, connective tissue disease, and then more rarely hypereosinophilic syndrome. So there is a differential diagnosis. So you have to, again, history is important. Don't just rely on biopsy results. You have to always go back to history. And when you're not sure, take another history. Bring the patient back, do a second history.
Thank you, sir. Thank you so much for that enlightening talk, sir. It was a pleasure listening to you. Thank you so much, sir. Now, Vedantan sir, Anil sir, we'll just finish. Vedantan sir's just 4-5 slides are left, and we will just culminate that talk, sir.
Yeah.
Can I ask a question to Dr. Anil, Dr. Vinay Mehta?
Yeah.
Yes, sir. Please.
Good evening, sir. I am Anil Arora. I am head of gastroenterology at Sir Gangaram Hospital, New Delhi.
Yes. Good evening.
The adult population do keep on suspecting a lot of patients with typical dysphagia, intermittent difficulty in swallowing, reflux, and even odynophagia. But our rate of diagnosis is less than 1% of what our clinical suspicion is. There is a gross disparity in our assessment on clinical grounds versus objectivity as obtained on esophageal biopsy. Majority of these patients turn out to either be having functional dyspepsia or achalasia cardia or reflux esophagitis. And it's only once in blue moon that you land up diagnosing eosinophilic esophagitis. Is it that it is less common in this part of the world?
We need more studies. Unfortunately, there's no dedicated Indian study. We know that anecdotally, for example, that in India you have a very, very high sensitization rate for food allergy, but very low prevalence of actual food allergy. And so could this be one of these disorders where in spite of a high sensitization rate, you may have low prevalence? It's possible, but I think it's important to do more studies. I think eventually, because of the westernization of India in terms of diet, lifestyle, this may catch up. So maybe currently you see low rates, but I think 20, 30 years ago it may catch up to the numbers we see here out in the West.
Yeah, the classical teaching in adult population of a typical ring-like appearances, typical concentric rings as seen on endoscopy, even they do not tend to match up with the histopathological proof of the above threshold pickup of eosinophils. So whether the pathologists are not tuned to seeing so many eosinophils, or maybe because usually by the time you take biopsy in esophagus, you are usually tangential rather than end-on. But it is a tubular organ. Taking multiple biopsies in a longitudinal tube is not easy.
Yes.
Maybe not even getting onto the submucosa. This could be the add-ons which will make you suspect eosinophilic esophagitis. The majority of these patients do ultimately respond to treatment for reflux.
Yeah, I think so it could be when you have conversations with your pathologist, that's one thing is are they, you want to make sure that their eosinophils are properly being stained with H&E, that they're properly being counted. There may be issues with sampling, how you sample. Now there are non-invasive ways, there's a esophageal string test, there's a sponge where you can measure the, in the fluid, you can actually measure eosinophils, you can measure T2 cytokines. Perhaps in the future, when those therapies are more available clinically, they may help in making the diagnosis. Certainly, one thing, as you mentioned, if people respond to PPI therapy, that's certainly something that you can, even though you may not confirm that they have EoE, if they respond to PPI therapy in these patients, I would probably just continue the PPI therapy indefinitely. There is an overlap. 50% of the time, you do see an overlap between EoE and reflux.
And the distal part of the esophagus is pretty prone to get infiltrated with eosinophil without inflammation, irrespective of the cause.
Yes, correct.
Not be EoE to begin with.
Yes. But those are great questions. I think we need more research. We need more epidemiological studies. And I think also the threshold for scoping should be lowered. So I would encourage everyone, anytime you have suspicion, please encourage the patient to get a scope, because that is the only way you can really pick it up.
It is a pleasure listening to your talk.
Thanks. Oh, thank you.
Thank you, sir. Sir, another question from Vedantan, sir. Is there any role of genetics in eosinophilic esophagitis?
Oh, clearly, yes. There's clearly genetics. That's why history is very important. So certainly, if you have a family history, there is a high rate. I don't recall the numbers, but there is a very high correlation, specifically with EoE, but also in general. You may not when you take a family history, there may not be EoE in the history, but definitely you will see a history of other atopic conditions. So asthma, atopic dermatitis, food allergy, allergic rhinitis, as I mentioned, oral allergy syndrome. So
I was more interested about genetics in the ethnic differences. The previous Dr. Arora asked about it's uncommon in India. So maybe our population is not prone because we may have it's very low incidence here. Maybe it's not picked up, or our population is not prone for this disease. Do you have any comments on that? Because we have several diseases like that.
Yeah, no, I'm not. No, I don't. I'm not an expert on genetics, but there may be epigenetics, maybe not genetics, but epigenetic differences that that make the Indian population less susceptible to EoE and as well as other conditions like food allergies.
No, is there any particular type of diet that, say, for example, like colon cancer, polyps, very common, quite common in the Western, but not here. They say it is basically depends upon the fiber content of the diet and all that. Is there anything like that here at EoE?
I'm not aware. I'm not aware.
Okay, thank you very much.
Yeah, thank you. Good to see you.
Nice seeing you.
Thank you, sir, for that lovely talk. Vedantan, sir, we'll...
I'm sorry. Yes, Soundarya.
Yes, sir.
I'm very sorry
go
about
to your
this.
talk. No problem, sir. No problem.
I am sorry about this technical issue. I think Dr. Neeraj told me I was in case scenario 6. So I'll finish up in 4 or 5 slides. I'll finish it up.
Okay, sir. Right, sir.
Yeah. So 6 was, this is a case of a very young infant, 6-week-old, with bloody stools, otherwise perfectly healthy, being exclusively breastfed. Mom is bringing this child extremely in distress because she's seeing red blood in the stools. And is this an allergic problem? What tests will you order? What is the probable diagnosis? Is this milk allergy? So with the clinical presentation like this, what it is it is not an IgE-mediated allergy. This is not, there is no sign of any mast cell activation here. This is a very classical type of intolerance to the cow milk protein. And this is protein, food protein induced enterocolitis or FPIES, which is self limited, fortunately. And the treatment is basically avoidance of milk protein. So the mom has to stop taking milk and milk products, and this situation will resolve. And after about a year or year and a half, she can again do a little minor challenge and see. And generally, they are able to handle it better, but sometimes it can last into age 3 or 4. And this type of problem can also occur due to other different food items also. So this is there is no test for it, and there is nothing. We do not know exactly what other mechanism could be involved other than it is an intolerance. So 52-year-old physician developed acute abdominal pain, nausea, vomiting 3 to 4 hours after Mexican dinner. Had consumed taco salad with warm water. Actually, he was my brother who went to this very nice restaurant, developed all these symptoms, was hospitalized. I was in ICU for 2 days. He even developed pre-renal uremia, got better, fortunately, was discharged perfectly fine. So is this allergy to that food that he ate in that Mexican restaurant? It is not. It is actually food poisoning. So once they investigated it further, the salad that was served, had lettuce in it, and lettuce actually came from a different country, from Chile, from South America, and it was contaminated with staph. So when you are eating in these restaurants, you need to be aware whatever you are eating may not be locally grown, not even nationally grown. It could be international. So there's a global situation you need to be aware of. And such things are going to get common in India also, because we are rapidly globalizing. So this is something you need to be aware of. This is not food allergy. This is food poisoning. And people can label it as, general public can say, oh yeah, this person had food allergy. But when you take more history and figure out, if you look at the whole thing, it is more of a food poisoning. 24-year-old male foot gets stuck, and this is EoE, which Dr. Vinay has completely beautifully presented in the past half an hour. So I'm not getting into this. So take home messages from my talk is adverse food reactions are very common, definitely very common. Out of the 8 cases I presented, 3 are from my own family. So you can imagine how common it is, adverse food reaction. But true food allergy is very uncommon. Very few people have true food allergy, especially in India. It is quite uncommon. And according to studies done by Dr. Mahesh and a few other investigators, the sensitization rate can be very high, 25 to 26% sensitization. But actual allergy based upon history, and temporal relationship and all that is less than 1%. And whereas the same population, when it moves west or to countries where developed countries, this can change. That is called acculturation. And so the child who is brought up in a Western environment is much prone to develop food allergies than a child brought up to genetically similar parents in India. So there's something in India that is protecting us. So food allergy is uncommon in India, right? Yet, but it is changing. It will change because of the food habits are changing, lifestyle is changing. History for us to pick it up plays a huge role. Tests are important, but they are complementary. I will stop here, open for any questions. Thank you.
Thank you so much, sir. So, questions are there. A celiac disease, is this a non-IgE mediated food allergy or is it food intolerance? Because it's IgA mediated,
No,
so
it
it
is
is
not IgE
immunological.
mediated. It is not IgE mediated. It can be an immunological problem. IgA is sort of blamed, but it is not IgE mediated.
So, can it be classified as non-IgE mediated food allergy?
Yes,
Because it's IgA.
yes, yes.
Okay. So, one more question. In your opinion, as a practitioner, or a gastroenterologist if a practitioner should or a gastroenterologist should order for a blood test for food allergy and send to an allergist, or he should refer the patient itself to the allergist, which is better? Should he investigate and then send, or send the patient directly before investigating, sir?
Blood tests, in vitro tests, specific IgE tests are notoriously known to not to correlate. with the clinical presentation. So we do not order any type of tests, especially the panel, food panel is notoriously inaccurate. So never order any type of food IgE, specific IgE. Get a good history if you have time permits. And Dr. Vinay actually does not even do testing with commercial extracts. He uses the actual foods for skin testing. If you are allergic, if the mother says he suspects milk allergy, he will tell the mom to bring milk and test with the milk. And I have several stories to back it up. But because of the question of time, what I would say is if the gastroenterologist should just refer the patient to a good allergist who will probably do a complete history. Based on that, he can do further testing if necessary. Please do not order any type of food panels, especially specific IgEs.
Okay. Thank you, sir. Sir, is there whey protein intolerance also existent as a part of milk intolerance?
Yes,
Whey
there is
protein?
yes, it is a part of casein. You see, in milk allergy, milk has got both heat stable and heat labile antigens. The heat labile antigens are the lactoglobulin, and that is the one that gets destroyed with heating the milk. So even after heated the baked foods, when you bake the food, there are children who cannot handle that also. That means they are allergic to casein, which is the heat stable portion of the antigens in the milk. So yes, it can exist.
Thank you, sir. Thank you so much. Thank you for sharing your valuable information. Thank you so much,
Thank
sir.
you. I'm
So good
sorry
to hear
about the
from you.
technical
Thank you, sir.
issue, and I
No
enjoyed.
problem, sir. Thank you.
I
Doctor,
have one question. Pardon?
can I ask a question, Dr. Vedantan?
Sure, sir.
Yes,
Sure,
yes,
sir.
yes.
Sir, first of all, an excellent talk. But my problem is in adult practice in gastroenterology. A lot of, as you had hit the nail on the head very rightly by pointing out that commercial tests are more often than not, going away from your diagnosis. They will never hit the target. And you ask the patient what food you like the most, and he will get a big list of the food item to which he is allergic. There is a gross mismatch between your in vitro assessment as well as his response to clinical challenge. And that is unfortunate. Every single food allergy test in vitro costs around 10 to 15,000. And especially with patient with IBS, it gets stuck up to their mind ki, you don't have to eat this, you don't have to eat that, when none of that has any meaning. So why are they still available in practice? That's my question.
Coming back to your initial part of the question, patient's perception of food allergy is entirely different from a physician perception. So if you ask, there are articles that say that 27% to 60% of food adverse reactions are ascribed to allergy by the patients, whereas the actual prevalence could be 1% according to physicians' evaluation. So patient perception can be quite misleading here. But so that is the reason why when we evaluate these patients, we have to go into much more detail about the chronological order of his symptoms. When did you take the food? When did the symptoms appear? What type of symptoms was it? So how long did it appear? And has this happened before? So all these type of symptoms, all this type of information will give the allergy specialist an idea. Is this an allergy? Is there mast cell activation here? Is it something correlating to histamine release? So this is a clinical type of approach. Say like you go ahead and do skin testing or you do specific IgA. What is the positive predictive value is only 40%. That means 40% of patients who show positive on specific IgE or skin test have clinical food allergy. Otherwise, 60% of patients do not have any type of food allergy, but they show up on skin testing, they show up on specific IgE. So the gold standard for food allergy diagnosis is, in addition to a good history, is what we call as oral food challenge, which we do. And this is done as an office procedure. A majority of the time is not done in cases where the history is not that strong. It's not like anaphylaxis. I took this nut, this particular cookie, and within 15 minutes, I had a throat that swelled up and I had hives. That is a strong history. You don't want to do challenge there. But where the history is vague, where I took this food, then my abdomen started hurting and I had diarrhea, vomiting, I'm allergic to this food, and this has happened several times. That's a weak history. These type of things, these people with weak histories are, that is called risk stratification. We do food challenge, open food challenge in the offices, and that is the gold standard for food allergy diagnosis, not specific IgE, not skin test. And when Dr. Mahesh did this study on Indian population, especially I'm talking about Indian population have very high IgEs. The normal IgE in the international could be 150. Here it's 350 to almost 500. So we have a lot of IgE directed against many, many non-specific things. And the IgE that we produce could be directed against carbohydrate content of the foods also. That is called CCDs. So, so this is something we need to be aware of. So when they looked at the correlation between skin test and specific IgE, they found that a huge number of people react to specific IgE much more than skin test positive. So specific IgE can really confuse everyone. So that is one reason why we do not do specific IgE for foods as a routine. I may do to confirm if the history is very strong. I may just do selectively or on a follow-up if I want to sort of decide on food challenge whom I should do or not. Then I do specific IgE, not for initial diagnosis. Now coming to your latter part of your question, why is this being done? Why is this being pushed? That is unfortunately, it is the laboratories, because it is extremely financially, extremely beneficial to these companies that try to push and push and push to have you do these in vitro tests. So you need to resist ordering these type of panels. Please do not order food panels using specific IgE.
Thank you, sir.
I know it was
Such
a
a
long
privilege.
answer. I could not help it.
But I think
Thank you, sir.
we can't have a more elite panel than this to recommend at national level. That is all useless tests. Doctor Nandan, if you remember, there used to be a test called Cassoni's test for hydrated disease. And we had Professor Samiran Nandi who would say that if Cassoni is positive, it cannot be hydrated disease, and if it is negative, it has to be hydrated disease. That was the foolish hardness and foolish hardiness of the positivity and negativity of Cassoni's test. So I think skin allergies on food allergy on paper is almost the same thing in commercial assays.
You see, the problem is people tend to simplify things too much. Food allergy is not that simple. Even for an allergist, well-trained allergist has problems with food allergy. So you can imagine a generalist or different specialist will have significant issues because it is very confusing. Because one hand patient is complaining, another hand skin test is positive, another hand specific IgE is positive. The allergist says no, this is none of these things are that great. Do food challenge. So there are many steps to make food allergy diagnosis reliably. So it is not as simple as it looks. So do not believe some salesman coming into your office and say, please order this panel, sir. And this will give you the answer. And that will give you more sleepless nights, not only to you, but to the patient and to the parents, because they will unnecessarily eliminate all these foods and they show up cachectic in somebody's office 5 years later. Thank you.
Thank you, sir. It was a privilege listening to you again. So good, reminded me of DPA days. Been really long. Thank you so much, sir.
I have
Thank
one
you.
question for you, Saundarya.
Tell me,
Is
sir.
there a panel discussion that we need to stay or can we go?
You can go, sir. No problem.
Is there
No
a panel
issues.
discussion?
Actually, sir, the panel was for all the questions which we accumulated together. But because of lack of time, I finished the questions along with the talks itself, sir. So nothing specific and we are running late. Thank you, sir. Thank you so much.
Thank you very much for all of you. Thank you.
Thank you, sir.
Thank you.
Thank you.
Bye-bye.
Our next session now is by Dr. Anil Arora, Sir is a well-known and esteemed gastroenterologist, hepatologist at Gangaram Institute of Postgraduate Medical Education and Research at Delhi. So, as we are running late, I will not go further. Over to you, sir, for your session on inflammatory bowel disease.
Okay. Are my slides visible?
Yes, sir.
Okay.
They have just go on slideshow, sir. That's all. They're in the presentation mode. Just go to slideshow, sir.
Yeah.
Yes, sir. They're fine, sir. Right. Thank you, sir.
I am going to be the odd man out when I am talking of something different from allergy. But I believe that this type of understanding which I am going to present today is going to be the basis of how do we develop energy after consumption of various elements of the food. So it's just a role of allergy and immunity in patient with inflammatory bowel disease. That is the concept. So what I'm going to talk to you and tell you about it. What is inflammatory bowel disease? How does the immune system react to the incoming antigen which are consumed during the food ingestion? And what is the crosstalk between the microbiota and the immune system? So I think this 5 minutes of video, if Dr. Sondria permits me, is going to give you an excellent overview of what our normal physiology is. In the normal course of the events, any type of food, is the video seen clearly? Hello, is the video seen clearly? As the food travels down the mouth from the oropharynx into the esophagus, and from the esophagus the food tends to get into the across the G junction into the stomach. In the stomach, because of the presence of the acid, most of the bacteria are taken away by the acidic hostile environment, but some of the obstinate bacteria and the microbiota, they tend to go into the small intestine, which is lashed and covered with this large number of the villus patterns which are important for the absorption of the food. Interspersed in that, you have this globular structures called Pierce patches which are spread throughout the small intestine. And this is how a typical Pierce patches looks like. As the food is traversing from the intestinal lumen via the lacteals into the submucosa and the lamina propria, you have antigenic stimuli which are stimulating these mesenteric cells. So these incoming food material or the components of the food get activated, and then you have these areas in which the mesenteric lymph node through the Pierce patches, they go into the nearby lymph node, and from there they come back into the circulation. In the intestinal lumen, if you see, you have something called M cells. This is the cell which is so important for transgression of the luminal contents into the subluminal area or submucosal region. So the incoming antigen, like a food antigen, will traverse across these cells and will end up in the lamina propria, where you have dendritic cell which is ready to pounce upon it. So any new incoming antigen is well taken care of by this protective dendritic cells or a natural killer cells. At the same time, dendritic cells keep on pushing up this antennae up into the intestinal lumen and keep on catching the antigens so that they come back to the lamina propria for the body to get used to the food which we take, something which gives you a tolerance. As the dendritic cells tend to get these incoming antigens, they go and stimulate the naive T cells, and these naive T cells are then converted into T regulatory cells or T reg cells. The basic purpose of these cells is that they tend to produce, and once you have activation of these cells, they'll go back into the circulation, and from there they'll come back into the lamina propria. So you have, in a normal course of the event, you have a lot of sensitized T cells which are known to be producing anti-inflammatory or tolerant cytokines like IL-20 or Treg cells. So in the normal course of the event, you get tolerant to the food which you are consuming right from your childhood. But let's see a condition in which there is a bombardment of the mucosa by injury, mechanical, chemical, or thermal, and you have a lot of antigens which tend to pop up into the submucosa. Now, this poor dendritic cell is not able to cope up with the incoming antigen load and ultimately tends to get onto the lower level because it's not able to cope up with the incoming antigen load. So you have natural killer cells and the and macrophages which are present in the vicinity. Then they come and try to take care of this incoming antigens, the load which was not being handled by the dendritic cells which were producing pro-inflammatory cytokines. So these Cooper cells, then they start producing pro-inflammatory cytokines in the form of IL-6, IL-12, and IL-23. As these cytokines, they move and go and try to act on the effector cells. Now the effector cells will produce another pro-inflammatory group of cytokines like interferon gamma or TNF alpha. So now you have created a milieu in the submucosal region, in the lamina propria, where these pro-inflammatory cytokines have decreased and there is a large number of neutrophils which have been attracted by the pro-inflammatory cytokines. So you are producing a big, huge neutrophilic extracellular trap or NTP. The purpose of this trap is to limit the inflammation which was caused because of the disruption of this epithelium. So slowly and gradually, in the natural course of the event, you will have the scavenger cells, natural killer cell, macrophages, etc., will come and eat away this neutrophilic extracellular trap, and the milieu is restored. So you have regeneration of the dendritic cells, the cells which were producing anti-inflammatory cytokines like dendritic cells or IL-20 and IL-10, they'll come back into the lamina propria, and so there is a restoration of the epithelium. So in case of restoration of the epithelium, what is happening is that you have been able to get back to the normal cell. But let's see what happens. Are my slides visible?
Yes, sir, your slides are visible. Please go ahead.
So what happens with passage of time is that with repeated acts of inflammation and injury to the protected mucosal defenses and the mucus layer, you will have repeated inflammation episodes and activities of inflammation occurring in the lamina propria and submucosa, which the body's own defensive mechanism is not able to cope up. That is what results in different type of phenotypic expressions of two distinct diseases which we see in our adult gastroenterology called Crohn's disease or inflammatory or ulcerative colitis. There is a basic difference between the two, that Crohn's disease affects almost all parts of the body. It usually results in transmural inflammation and presents a skip lesion. That means you do not need to have a diffuse involvement throughout the colon, whereas ulcerative colitis is primarily limited to the colon. It is characterized by not transmural but mucosal inflammation, and it tends to give you continuous lesions. So this is the basic phenotype which we see on day-to-day basis because of the repeated attack of defenses onto the conserved mucosal surfaces. So ulcerative colitis primarily localized in the colon. It may be on the left side of the colon, in the distal colon, in the whole colon, whereas it is usually by default a diffuse continuous process involving mucosa. Whereas if you look at in the Crohn's disease, the typical phenotypic pattern is it will give you a number of other complications like patchy involvement, structurization of the colon or the small bowel because of the transmural involvement, and even perforation and fistula. So why do we develop this type of inflammatory processes which tend to occur? Uh, Dr. Somendra had recently asked, what is the contribution of genetics in patients with allergy? I believe that other than non-infectious disease, anything and everything which occurs in the human body has to have a genetic component. So you are predisposed to have inflammatory bowel disease once you have a smoker, or if there is a history of appendicitis. These are the condition in which there is a protection to development of ulcerative colitis. So smoking, in fact, is the only condition which tends to be useful in a particular set of patients, that is those who are likely to develop ulcerative colitis. If you have had history of appendicitis, then your chance of getting ulcerative colitis is less. So these two events are the events which are likely to be protective in causation of ulcerative colitis if you have had any of these events like smoking or history of appendectomy. But there are other conditions which predispose to development of ulcerative colitis. There is a basic difference between the two conditions. Ulcerative colitis typically is a disease which presents with involvement of the colon, presenting as abdominal pain, loose motion, tenesmus, diarrhea, bleeding per rectum, etc. Whereas a Crohn's disease may start anywhere from the esophagus via the stomach into the small and large intestine. Since it is causing transmural inflammation, it usually comes up with conditions like obstruction, intestinal inflammation, uh, development of the fistula, perianal fistula, etc. So that is the basic difference between ulcerative colitis and Crohn's disease. If you look at the mucosa, you have only superficial involvement of the mucosa. So even if you want to try to see the improvement in terms of the therapy which you are giving, a simple mucosal healing is very predictive of a long-term response and remission of the treatment. Whereas if you want to see the response and remission in patients who are having transmural disease, you may have to bank not only on biopsy but also radiological evidence to see what is the degree of thickness of the bowel which is involved with in patient with Crohn's disease. What is have been happening to the global epidemiological map of IBD evolution? In fact, this is a disease which has been rapidly increasing. I'm sure most of the practicing gastroenterologists realize a large number of our patients who are young entrepreneurs or people who are going to do their graduation and post graduation in the Western world, especially Canada and US, within few years of landing there because of the lifestyle changes in the diet, allergic phenomena, or the stress in an underlying genetic predisposition, they tend to develop inflammatory bowel disease. As Dr. Vedantan and Dr. Vinay were trying to tell us that these are diseases of westernization. As we are getting economically more prosperous, as our GDP is increasing, I think we are seeing more and more of these conditions. What is the role of immune system and how does allergy come into play? Immune system by default is a double-edged sword. So you have two components of the immune system. You will have innate immunity, which tends to prevent you from invading organisms which tend to come into the food, or invading allergens which are ingested as a part of the new varieties of the food which you go and eat in various different geographical regions of the world. Innate immunity by default is rapid. It is non-specific because, as I showed you in my video, it consists of macrophages, neutrophils, and dendritic cells, epithelial barrier, etc. Whereas adaptive immunity, which tends to develop with passage of time, whether it is related to the IgE type of allergic phenomena or T cell or B cell mediated Th1 and Th2 response, it is a specific immunity. It is slow to start, but it is definite. It is going to protect you for a longer period of time. Now, innate immunity is something which is going to take care of all incoming allergens or infectious agents, whereas adaptive immunity is going to take care of something which has not been taken care of by the innate immune system. You have to have a balance of innate immunity, which tends to neutralize the incoming antigen as the incoming antigen, either in the form of food allergen or a dietary component of a microorganism or the various antigens produced by the microbiome in the gut. It tends to go and enter the immune system of the body through the submucosa, but innate immune system at times is good enough to take care of this by production of anti-inflammatory cytokines including IL-10 and TGF-beta. But also with adaptive immunity, it's able to take care of invading microorganism by producing pro-inflammatory cytokines and producing neutrophilic extracellular traps which are taken care of by the adaptive immunity. So in the natural course of the events, you need to have reversal of this immunity which was triggered by the breach of the mucosa so that you can come back to the innate immunity. Somewhere down the lane in patient with inflammatory bowel disease, there is a mismatch between the return of adaptive immunity to the baseline level. That means once there has been a trigger because of the incoming antigen, be it a part of the food or the microbiome, the adaptive system, because of the genetic predisposition, fails to tone it down, and the pro-inflammatory components does not get toned down. So the imbalance between the innate system, which is giving you protection from the very beginning, leading to activation of the adaptive system whenever there is an acute injury or a huge amount of the load of antigen which is transgressing the protective boundaries of the epithelial mucosa. In the normal course of the event, there should be a complete reversal. Somehow, in patient with inflammatory bowel disease, that balance tends to weigh more in favor of the start of the adaptive immunity, perpetuation and maintenance of the adaptive immunity, which tends to give you a disease called inflammatory bowel disease. So, how do we see it in vitro and in vivo studies? So, this is the incoming. This is the gastric lumen, which gives you a host of proteins which are usually taken care of by the Pierce patches, as some of the antigens tend to come into contact with the mucosa because of the breach of the defenses or because of the disruption of the mucosal layer, say by injection of NSAIDs or by causation of food poisoning or by bacterial infection, Shigella, amoeba, etc. So the Pierce patches, they tend to develop this, they tend to catch hold of this incoming antigen and will mount an immune response which goes into the circulation and will land up in the lamina propria. So in the normal course of the events, the gut associated lymphoid tissue is good enough to give you a protection from the incoming antigen which we are swallowing on day-to-day basis. So this is an important component of any injury which is occurring in the gastric epithelial mucosal defenses, either because of the disruption of the tight junction or because of the dissolution of the mucous membrane or direct injury to the epithelial mucosa. So you have gut associated lymphoid tissue which is able to take care of in day-to-day defenses. But somewhere down the lane, because of the problems either in the genetics, in which these pro-inflammatory cytokines take over the anti-inflammatory cytokines and tend to produce more injury rather than trying to heal them. You may have a host of the gut microbiota which is producing a number of neoantigens which are not recognized as self by the body's immune system. And then, as I said, there is an uncontrolled immune response in the form of adaptive immunity which fails to tone down even after the incoming and triggering stimuli have gone. And this persistent, repeated, repetitive, monotonous inflammation will keep on increasing, resulting in increased tissue destruction, mucosal inflammation, and phenotype with which the patient comes to you with history of loose motion, abdominal pain, or etc. Do we ever realize what is the contribution of the various components of the genetics, environment, epigenetics, microbiota, or inflammation? It is important that Dr. Neeraj and Dr. Samadra has and Dr. Sondria had this seminar today to realize that major part of whatever injuries occurring in the GI tract in patient because of incoming food allergy and the antigen is related to the immune system. So look at the contribution of the genes. It is hardly any. Look at the contribution of environment or the diet. We stress so much on environment, diet, we tend to blame the patient. But what is happening is a uncontrolled, unchecked, unbridled inflammation, which is frattering the perpetuation and maintenance of the immune system. And hence, if you look at the drugs which we use for inflammatory bowel disease, and you'll not be surprised that majority of the drugs are taking care of the exaggerated immune response, which is the key for treatment of inflammatory bowel disease. So there is a what is this being triggered? Is it because of the microbiota? There has been some data to show that there is an imbalance between the bacteria which are useful for the gut, which tend to give you anti-inflammatory components and tend to respond by attenuating the inflammation compared to a number of the bacteria which tend to stimulate the inflammation. So this imbalance between the microbiome is what gives you the development of phenotype of ulcerative colitis versus uh, Crohn's disease as a clinical manifestation. And this is another way of looking at what is the contribution of genetic involvement. If you look at the monogenic disease, you have diseases in which there is an early onset of IBD primarily due to overactive due to defects in anti-inflammatory cytokines. That means if you are not able to produce anti-inflammatory cytokines like IL-10, IL-10 receptor antagonist, and IL receptor antagonist B, so you are more likely to have pro-inflammatory cytokines. But this monogenic IBD, which tends to occur in a very severe form, occurs only in 10% of the patient, that too in early childhood. As one increases in, as one tries to age, the component of environment and the over exaggerated immune response come into play. So if you look at the contribution of genetics to development of inflammatory bowel disease in adult population, most of it is polygenic, whether it is acquired because of the environmental stresses or it gets changed over from congenital mutations to epigenetic changes which manifest in phenotypic expression is still not known. And in fact, there is a also when we talk of microbiota or the gut, we should also remember that gut is the largest organ in the body. You have the stomach, you have small intestine, you have the large intestine, you have the rectum. And when we talk of microbiota in general, this microbiota is totally different. As Dr. Mehta said, that eosinophil count is variable in different parts of the gut. So is the type of microbiota, the number of the microbiota, as well as the species of the variation in the diversity of the microbiota. So to label the whole gut microbiome, yeah, as one single agent is it's saying that all countries are one, which is not true. We have 190 countries in the world which have their own identities. Similarly, the different components in the different parts of the gut microbiota are different with different components. Hence, we are not able to characterize as of now. The basic difference in healthy subject and a person who develops inflammatory bowel disease is that the problem can occur at the level of obnoxious bacteria which are harboring in the small intestine. There may be a problem of epithelial defense mechanism. There may be disruption of the mucosal layer. There may be weakening and or attenuation of the tight interstitial junction, or there may be an abnormal exaggerated response of the cells which are lying in the lamina propria. So a large combination of various etiological factors may be combined together to give you a composite picture of inflammatory bowel disease. When we say that we know something about immunology, I think we know very little about it when there are so many factors and so many players trying to contribute to the final outcome of the phenotypic expression. It is very difficult to pinpoint where did the problem start and how to do we go about it. But this is the basic difference. In the normal course of the events, you have a thick mucosal layer, you have the useful bacteria which are producing by a host of which are producing a number of substances like short chain fatty acids which are important for nurturing and maintaining these Paneth cells. Paneth cells are cells which are so important for maintaining the integrity of the intestinal mucosa. Then you have the dendritic cells which by default, even if there is an incidental transgression of this boundary, so they will try to give you only T regulatory cells and not stimulate the T effector cells so that the inflammation is toned down and taken care of in the submucosa only. It is only when your bacteria are bad or when you have disruption of the interstitial junction or when you have obnoxious bacteria or you have exaggerated response in which this dendritic cells is more prone to produce TNF alpha rather than IL-10. So this genetic mutation of IL-10 which is not produced will produce only pro-inflammatory cytokines resulting in causation of inflammatory bowel disease. So if you try to summarize what happens in patient who develop uh, uh, inflammatory bowel disease, you have environmental, genetic, and immune factors which disrupt the intestinal barrier, allowing microbial translocation into the lamina propria. In the normal course of the events, dendritic cell and macrophages they activate an inflammatory cascade by presenting antigen to the T cells and B cells. In the normal course of the events, the T cells will produce Treg cells which will try to control and attenuate the inflammation. But if there is a unregulated, unchecked, unfettered inflammatory cascade in which you are producing more pro-inflammatory cytokines like IL-6, IL-12, IL-20 and 23, then you are more likely to come back with inflammatory cascade. And hence, as of today, if you look at the way the therapy is progressing in inflammatory bowel disease, even today, as of 2025, the crux of treatment of inflammatory bowel disease is by subsiding the inflammation and trying to tone down the inflammation by a number of anti-inflammatory drugs. As we are understanding more and more about the various inflammatory processes, including the role of T cells, B cell, the intermediates, the interleukins, and the cytokines, we are using the specific therapies like anti-TNF antibodies. And finally, we may be coming to a stage where we'll be using it in a personalized manner, depending on what type of cytokine is exaggerated and giving you pro-inflammatory state. We may be coming on to the specific etiological therapy, specific personalized therapy in a given individual, based on the particular cytokine profile, which can be assessed with the passage of time. So this is the emerging therapy and future direction for treatment of inflammatory bowel disease. As of now, we do not know whether it is whether these are the luminal factors, epithelial factors, intercellular junctional factors, or the factors which tend to produce less of anti-inflammatory, more of pro-inflammatory cytokines, which are the chief culprit in a given individual. So till we know, ladies and gentlemen, there is what we know today is that there is a good interaction of gut microbiome and intestinal immunity. Innate immunity in general tends to give you a rapid, non-specific response, whereas adaptive immunity gives you a specific and memory-based response. The only problem with adaptive immunity, which to some disadvantage, some disadvantage to all of us, is that it still has a memory. 10% of all cells which get activated are stored in the body as memory cells. They tend to reside even in the body even once the stimuli which has triggered the response is gone. So this immune dysregulation, which is persistent over a period of time, leads to immunity, and a combination of dysbiosis will further lead to reduction of the bacteria which are useful for the gut and have more bacteria which are supposed to be vicious. So the loss of mucus layer and increased permeability will lead to the Pierce patches, which get signals from the lymph nodes to go and activate the immune system, leading to the release of the pro-inflammatory cytokines. So depending upon your genetic component and the type of the cytokines which get excited and which tend to have pro-inflammatory components, a futuristic therapy will have specific therapies targeting against agents like TNF, JAK inhibitors, anti-integrin antibody, and as the new drugs like golisocumab or risukunimab are coming, you have specific anti-IL-22 and 23 antagonists, which will be, rather than giving a general non-specific immunosuppression, they'll be targeting the specific cytokine overproduction and certainly will have much lesser side effect. To conclude, ladies and gentlemen, IBD is driven by a dysregulated immune and adaptive immune exaggerated by dysbiosis in presence of genetic and environmental factors. It is a disease which is rapidly evolving, and I am happy that Dr. Sondria and Dr. Neeraj have come up with this issue, something which affects not only the adult but also the pediatric practice. Current therapies as of today primarily target key immune pathways but have their limitations because we still are not sure what is the given key immune pathway in a given individual. Emerging therapies and AI-driven therapies approaches will give us more hope for a personalized care because the side effects will be much less if you are specifically targeting a particular cytokine, which is the culprit in a given patient. And hence, we need more collaborative research with all the stakeholders. With that, I'll end up my presentation, stop sharing the slide, and go back to the organizer.
Thank you so much, sir. That was a very lovely talk. Really enjoyed listening to the depth of information in pathogenesis of IBD. Sir, just one question, sir. The extraintestinal manifestations of inflammatory bowel disease, can they occur in isolation as well and without primarily GI manifestations? Or can relapses also present with primarily extraintestinal features and not primarily intestinal symptoms?
Absolutely. That is a very relevant question. If you remember, I was talking about something called memory cells. So what happens is that once you have an adaptive immunity, some percentage of the cells which have been exposed to a particular antigen are likely to retain their potency to produce a particular type of response to an incoming antigen, even if the antigen is gone. Nobody knows where these cells reside. Possibly they reside in the bone marrow. And once there is a repeat exposure anywhere in the body, these cells are likely to migrate from the extra primary sites, say, let's say extraintestinal site, back into the circulation And because, say, in ulcerative colitis, you also have primary sclerosing cholangitis. So in that subgroup of the patient, in which there is a molecular mimicry between intestinal antigen and the bile duct epithelium. So a sensitized memory cell which is roaming free in the circulation is likely to catch hold of that extra intestinal area and attack it even if you have removed the intestine. It is very well known that even after removal of intestine in ulcerative colitis, you can have exaggeration of primary sclerosing cholangitis.
Thank you, sir. That was so nice. So, just one doubt, sir. We had a child who was drug allergic to NSAIDs and developed Crohn's disease with fistula. We don't have the option of mesalamine in that because it is aminosalicylic acid derivative. So, for such children, the gastroenterologist here had advised infliximab. So, this infliximab, how long the course goes on? Is it means where is the end to this infliximab, sir?
Yeah, no, if you see the current concepts in management of Crohn's disease, you are chasing it to healing. So even in Crohn's disease, if you see in clinical practice, there are varieties of phenotypic manifestation, mild, moderate, or severe. Mesalamine is very good drug in ulcerative colitis. It's not a good drug for maintenance in Crohn's
Okay.
disease. Even though most of us tend to use mesalamine in patient with Crohn's disease, but Crohn's disease has mesalamine has no role in Crohn's disease. In Crohn's disease, the drugs of choice are biological or drugs of immunosuppressive agents like steroids and azathioprine and the new biologicals. Problem with new biological, as you very rightly pointed out, is how long to give. The question is, at least once you have started on drugs like infliximab, you may have to give it for as long as 1 year to begin with, and then you start tapering it for a period of 2 months. And depending upon the response and relapse, you may have to restart it. Everything boils down to the fact that we do not know where did the trigger come from and has it disappeared or not. So in a patient who has an advanced fistulizing disease, you want to continue it much longer than in a patient who only has diarrhea and loose motion without strictures and fistulas.
Thank you, sir. Thank you so much. It was a wonderful session. Really enjoyed listening to you. Thank you so much, sir, for sharing
Thank
your
you
time and
for
experience with us. Thank you.
and for inviting me for this wonderful gathering. I was so happy to learn from the lion's mouth of whatever is best known for allergy in Indian scenario too.
Thank you, sir.
Thank you
Thank
for
you so
joining.
much.
Thank you.
Okay.
Thank you.
Bye.